Okay, so thank you everyone for coming to another BIMA event. It's really lovely to see you all here, and hopefully you've been to our previous events too. So we're carrying on the clinical crash course with Acute Resp, which is great. We've got a lovely F1 doctor, Nafisa, here to go through today's and next week's session. So please come along to that as well. Nafisa, take it away.
Hi, so I'm Nafisa, and yeah, so we're just going to go through a little bit of Acute Resp, and if anyone has any questions, obviously jump in. So I thought one of the first things that would be quite good to go through is chest X-ray interpretation. It's something that you'll probably be asked to do a fair amount, and if I find if you've got a good system to go through, it's not so daunting, especially when you're presenting or if you've been asked to chase a chest X-ray when you're on call. So essentially, you want to confirm the details on the radiograph are the same as those of the patient you're expecting the X-ray to be for. So most radiographs have the patient's name, either their age or date of birth, and the time and date the film was taken. And that can often be quite helpful because you can track progress of conditions or compare radiographs from one to another. So for example, if you're seeing how a patient's condition has progressed over the last 4 years or something, that could be quite useful. When you're looking at the quality of the image, you can use the acronym RIPE. So you start off by looking at the rotation of the person. If they're not rotated and if the film is a central film, you'll have the middle bit, so the medial aspect of each clavicle, being the same distance from the spinal processes as one another. Often you use the clavicle with like C7 or something like that, and just because of the way it lines up, that's a bit easier. If a person's taken a good breath in, you should be able to see 6 ribs anteriorly. Some people can inspire and you can see more than this, and that's quite common in things like COPD. But yeah, you want 6 anterior ribs, and you should be able to see both costophrenic angles as well as the lateral rib edges. Someone who's not inspired properly, you might not be able to see the costophrenic angles because the diaphragm hasn't quite gone low enough. You want to know the projection of the image. Is it anterior to posterior, or is it posterior to anterior? The reason this is important is in anterior to posterior or AP X-rays, you can't necessarily determine whether the size of the heart is acceptable or not. You need a PA to be able to do that. And finally, your exposure of the film, essentially how well has the radiation gone through. And so for this to be adequate, you should aim to see the vertebra behind the heart. You can then do an A to E approach. So your A looks at the airway, try and comment on the trachea. If it's deviated, you want to know, is that because something's pushing the trachea one way? So for example, is there a mass or a tumour pushing the trachea the other way? Or is the trachea being pulled because of a difference in pressure? So for example, if you've got a pneumothorax or a collapsed lung, there's going to be less pressure in that lung, so the trachea will be pulled to that size. Your carina is the point at which the trachea deviates to the left and right main bronchus, and that should once again be quite central, and you should be able to see it. If you can't see it, you can ask, is there something covering it, or is there something within the carina that's making it brighter, for example? Your bronchi, your right bronchus is wider, shorter, and more vertical than the left. Often if you're worried about someone having inhaled a foreign object, it'll be stuck in the right bronchus because it is straighter and shorter, and therefore things are a little bit easier to get stuck. Hilar are the main pulmonary vessels within the lung, and you should be able to see those and try and comment on whether they look of a normal appearance or whether there are increased hilar markings. And lymph nodes shouldn't be visible unless there's an infective or malignant process going on within them. And your left diaphragm is usually higher, but the same size as your right diaphragm. And then you can move on to B, which is breathing. So when you're commenting on the lungs, you want to comment on the 3 different zones. Try not to go into the lobes, because firstly, it's quite difficult to determine exactly what lobe of the lung you're looking at. But also, as I'm sure you know, the right lung has 3 lobes and the left has 2. So that can just get a little tricky if you're in a bit of a panic. And make sure you look at the apices of the lungs. So these are the bits right at the top. They often are forgotten because there's not much that usually goes on there. You don't necessarily worry about things like infection, but they can be quite important. So TB often shoots right up to the apices. And it's the same when you're sort of doing your resp exam. Don't forget to auscultate the apices. So the pleura of the lungs aren't usually visible. If they are visible, start to think about whether there's something actually making them visible. So are they thickened, or are they infected, or are they full of, is there fluid between the pleura that's making you be able to see them? You then want to know if the lungs go all the way to the borders. If they do, that's great. If they don't, there's probably a little bit of air stuck between the lung and the border, which is essentially a pneumothorax. And then just take a look at if there's any fluid. Is that watery fluid? Is it blood? Is it something else? You know, could it be exudate or pus or something like that? Take a look at your bones. Are there any fractures? This is both old and new fractures. So often ribs can be fractured. If it's a new one, just take a look to make sure that there isn't a little bit of a pneumothorax around where the rib fracture is. And old fractures can look quite alarming. So I had a chest x-ray of a guy this week who about 4 years ago had been in a car accident and fractured loads of ribs. I saw his x-ray and his ribs looked wavy. It was completely normal. That was just the way they healed. But I thought there was something really bizarre going on. It took me a good 20 minutes to work out that actually he was all right. And then take a look at your heart. So that's where your C comes in. Again, you can't comment on the size of the heart in an AP x-ray, but in a PA x-ray, your heart should be no more than 50% of the width of the thorax. And then your diaphragm. Again, your right hemidiaphragm is usually higher than the left, but under neither diaphragm should there be free gas. If there is, think of something like an abdominal perforation. Often when you're sort of concerned about intestinal perforation, obviously try and get an abdominal x-ray, but also get an erect chest x-ray. The free gas goes up, gets trapped under the diaphragm, and you can see it, and therefore deal with it. Your costophrenic angles should ideally be well defined. In case anyone's unsure what they are, it's essentially where your diaphragm and your ribs sort of meet at the lateral side. If they're not well defined, or if the angle is a little more acute than you're expecting, it could be that there's an infective process and therefore some consolidation going on within that costophrenic angle. That often needs treating. If that is the case, sometimes you can say that there's blunting of the costophrenic angle. And also in things like pulmonary fibrosis, that could be a more permanent change. And so if you compare the x-ray you're looking at to a previous x-ray, you can take a look at whether this is a new and therefore more likely infective process or an older, more likely fibrotic process. And then you want to take a look at everything else if you haven't already commented on it. So were there any soft tissue injuries that you're concerned about? Any signs of surgical emphysema? That's usually in the upper zones of the lungs, and it's in the tissue, just the skin and fat tissue just on top of the ribs. Often happens when putting chest drains in and things like that. You get a little bit of air and then that builds up. And it can, when you touch it on a person, it feels like you're popping tissue paper. And essentially it looks like a whole load of bubbles and holes on an x-ray. Has the person got a pacemaker? Are there any tubes or lines that you can see? So do they have central lines? Are there any endotracheal tubes? Are they having any difficulty breathing? And that could be a cue with that. Do they have nasal cannulae that you can see, etc.? Artificial heart valves look bright, essentially because of the penetration of the x-ray. And the aortic knuckle you should be able to see, and just make sure it's in the right place and it's not twisted too much. So this is our first question. Maybe give you a couple of minutes to read it and have a think about it. I think there's a poll that you can use to answer it. Most of you thought it was severe. Let's see. Essentially, it's life-threatening. The way you can tell is you've got a young girl, she's got asthma, short of breath with an audible wheeze, so she's having an asthma attack. She's very, very tired, and that's one of the defining, so exhaustion is a defining factor for life-threatening asthma. Her heart rate is normal, that's nothing alarming. Her blood pressure's pretty okay, it's not awful, it might be a little bit low for, sorry, her heart rate might be a little low, but that's okay. Her ABG shows O2 of 90%, so if it's less than 92, it's either severe or life-threatening. And her CO2 is normal, which is good. So that would make it life-threatening. The next slide, we can go through why it is. Oops. Okay. Essentially, life-threatening asthma is this one here. It's when your O2 is less than 92%, your peak flow is less than 33% of your predicted value, and that's done on the little peak flow chart. Your chest might be silent, which means you can't necessarily hear a wheeze, and that's really worrying. People can be making poor respiratory effort because they're tired, so that's where the exhaustion comes in. They may have altered consciousness because they're so exhausted or so focused on just being able to breathe that then, you know, they might have a GCS of 13, 14. And sometimes they can be cynosed. Again, they can be quite agitated. An asthma attack can be quite scary, especially if you're young or you've not had one before, or you've had one before and had a really bad experience. And I think also in children, sometimes having their parents in the room can be really reassuring, but sometimes their parents might just need to take a moment to step out of the room, calm themselves down, and then come back in, and that's okay. In terms of asthma that's not life-threatening, severe asthma, again, your O2 sats are below 92%. Your peak flow is between 33 to 50% of the predicted value. If you're less than 5, you'd have a respiratory rate of over 40, whereas if you're over 5, it would be about over 30. The reason that is younger children have a higher respiratory rate normally anyway. People may be too breathless to talk or feed. A heart rate of over 125 if you're over 5 and over 140 if you're under 5. Again, the heart rate is often higher if you're a bit younger. You can use accessory muscles. So things like that, you might be using abdominal muscles to breathe. You can get recession of your costophrenic muscle, of your costal muscles as well. And you would probably be able to hear a wheeze from the side of the bed. You wouldn't necessarily have to auscultate. Whereas if your asthma is mild or moderate during an attack, your O2 sats are maintained at above 92%. Your respiratory rate isn't necessarily raised. You've not really needed to use your accessory muscles, so your stomach isn't going in and out. Can often just be talking in full sentences and sort of just know that you're a little more breathless or know that your breathing isn't quite as easy. And you can hear a wheeze. Sometimes you just need to pop a stethoscope on the chest to be able to hear it. You can't necessarily hear it from the end of the bed. Often people will know when their asthma is really bad, and so you would probably just trust them before kind of going into, well, let's figure out which this is. Essentially, if you overtreat asthma, that's okay in like an acute attack, rather than undertreating it, which can actually shift the attack from mild or moderate to severe or even to life-threatening. Okay. So essentially, someone who's having an asthma attack will be acutely breathless. It can come on quite suddenly, and they'll be wheezy. The way asthma works, or rather doesn't work, it's more an expiratory wheeze you hear, because you can suck air in, but it's pushing it out through the narrowed airway that creates that wheeze. It's a polyphonic wheeze, and it's an expiratory wheeze. So how do you manage it? The first step is salbutamol. With asthma, you want 5 milligram nebs of salbutamol, whereas for COPD, you can get away with 2.5. So you want nebulizers, you want to give it either back to back, which means continuous. You use one for 5 to 15 minutes and then pop another one on and then another one on. Whereas for more maintenance, you can just use them 4 times a day, so QTS nebs. You give oxygen. You can either give that through your nebulizer. So if you're using salbutamol nebulized on oxygen, or sometimes you need to do salbutamol nebulized on saline if it's an infective process driving the asthma exacerbation. You want prednisolone. You go with 40 milligrams for 5 days orally. If the asthma is really severe, or you're unable, or you're unsure that oral steroids are the way to go, you can always give hydrocortisone, which is instead of prednisolone. You'd go with 100 milligrams IV. You do both of these stat, and then it's once daily after that. If that's still not helping, you want to repeat your salbutamol, and you can also add in ipratropium. So ipratropium bromide is another type of nebulizer that you can use, and you use 0.5 milligrams per hour. Your magnesium sulfate is IV. You give it over 20 minutes. If you've got to this stage, it's probably more like it's life-threatening asthma than sort of mild or even severe. So you give 1.2 to 2 grams IV over 20 minutes. If you can do this in a larger cannula, that's really helpful. Magnesium sulfate is quite irritable to the inside of a vessel. So if you're trying to push this through a blue cannula, it's going to be a lot more irritating and also a lot more difficult, which is why ideally in emergency rooms, you just go for the green cannulas straight away. If the person's got really tricky veins, you can go for a pink, but ideally nothing smaller than that. And then you want to continue your prednisolone for 5 days. You then go for nebs 4 times a day. After that, you can step down to inhalers. Before a person is discharged from hospital with an asthma attack, they need to have been off nebs and on to inhalers for at least 12 hours, ideally 24. And their peak flow needs to be 75% of their predicted. Okay. Our second question. The answer is C. You want oral antibiotics. You want amoxicillin and clarithromycin. Why you want this is essentially you've got a 67-year-old, so not a young person. They've got a little bit of chest pain with a productive cough. It's a pleuritic type chest pain because it's worse when they breathe in. They've got a raised temperature, a pretty raised respiratory rate. The heart rate's a little bit tacky and their blood pressure is slightly low. And their urea is 6 millimoles. Essentially, that can be used to calculate what's called your CURB 65 score, and we'll come on to that in a minute. When you examine the person, it's dull to percuss over the right middle lobe. I'd also expect them to have slightly reduced air entry on the right, and it could be quite crackly on auscultation, especially over the right. And then if you take a look at the chest x-ray, that's your main sort of source of consolidation. So with this, you don't necessarily need IV antibiotics. I'd probably want gram-positive and negative cover if possible. Go with oral Comox. They've probably come in from the community and they've just come into A&E. So go with oral Amox and some clarithromycin, obviously for someone who's not penicillin allergic. A quinolone isn't needed in this. You definitely don't want to not give your penicillin cover if possible, so don't just go with oral clary. An IV Comox is probably a bit of a step too far to start off with. So with pneumonia, essentially it's an acute lower respiratory infection. You can have community-acquired pneumonias, which are called CAPS, hospital-acquired, which are HAPS, which are, by definition, you have to have been in hospital for 3 days before getting a HAP, or have left hospital within, it used to be 14 days, but I think it's now 12 days. You can get aspiration pneumonia, which is essentially when something you've swallowed has gone into your lung, or a little bit of vomit has gone into your lung. It's really common in people with an impaired swallow. So for example, if you've got MS and your swallow isn't great, and you're eating some food, you then choke, you vomit a little bit, and then a day later you're short of breath, crackly, have a temperature, that's probably an aspiration pneumonia. And you get atypical pneumonia. This sort of covers pneumonias that are caused by bacteria that aren't the usual ones you'd expect, so they're not your usual staph. You can get Legionella pneumonias, and also pneumococcal pneumonias. People with pneumonia, which is essentially a lower chest infection, are pyrexial, so they have a fever. Usually it's above 38, but not always. They can be short of breath. They often have a productive cough, but sometimes people just come up with just a cough, and that's often because they need a little bit of a nebulizer in order to loosen the secretions so that they can produce the sputum for it to be a productive cough. And they get pleuritic chest pain, so it's worse when they breathe in. When you examine their chest, there's reduced expansion on the side of the infection. It's dull to percuss. You get bronchial breathing, so they tend to breathe from higher up in their chest rather than sort of the lower lungs. The air entry is reduced on that side, which is why you get the reduced expansion. It's crackly, and it's positive for vocal fremitus, so you can sort of hear the secretions or the infection gluggling about when they say 99. So when you do bloods, you'll have raised inflammatory markers, things like CRP and white cells will often be high. They tend to follow one another. So if your CRP is high and your white cells aren't high, it's possibly not an infection, and vice versa. Their oxygen sats will be decreased, and that's because their lungs just aren't dealing with the infection enough for them to be able to perfuse the body enough. So you're not getting enough oxygen into the lungs, which is then not going round in circulation. Consolidation on the chest x-ray, which we saw in the previous slide. Consolidation looks more white, essentially. You can get little pleural effusions around where the infection is, or sometimes even below it. If it's a middle zone infection, you can get pleural effusions in the lower sort of costophrenic angles and things like that. And you can do cultures of sputum. So if they are producing sputum when they cough, send that off to the lab, get MCNS and PCRs and things like that. And also send off their urine if you're concerned about atypical infections, which you often think of in older people, so above 65, or those with COPD or other immunocompromising conditions. Again, you want to look for things like Legionella and pneumococcal antigens, which you can find in the urine. So we're talking about the CURB 65 score. Essentially, it's the number of points of this that tells you whether a person needs to be treated with oral antibiotics or IV antibiotics, and whether they can be treated at home or in the community, or whether they need to come into hospital. If they're confused, that's a sign of a more severe infection. If their urea is greater than 7, or their respiratory rate greater than 30, if their blood pressure is essentially not holding up, so they've got a systolic less than 90 or a diastolic less than 60, so they're hemodynamically unstable, and if they're over 65. So low risk, give them amoxicillin and send them home. Moderate risk, so our lady, she was over 65, and I think she had a slightly raised resp rate, if I'm not mistaken. Let me just go back. Oops. Yeah, so her resp rate was 32. She's over 65. So she's already got a CURB score of 2. Her urea was 6, so we're not necessarily concerned about that. She's not confused. Her blood pressure was holding up. So she's got a CURB score of 2. So you want to give a macrolide and amoxicillin, which is why you gave amoxicillin and clarithromycin. Probably admit her at least for 24 hours, make sure she doesn't get any worse, but you can still use oral antibiotics. Often, certainly what happens at the hospital I'm at, these people will get antibiotics. You'll give them a dose when they're in hospital, IV, because they've come into hospital. And everyone always needs a little bit of fluid. It's the greatest thing you can give anyone. And then they'll get sent home with follow-up in an ambulatory unit in about 3 days, just to make sure they're doing okay. And that kind of saves you admitting them, which at the moment we're really trying to do. Things are getting a little bit more pressurized. And if they're high risk, you want to go with IV antibiotics. You want cover from both your Kermox, not amoxicillin, it's not going to be good enough. And you also want your macrolide. In people who have a CURB score of sort of 4, 5, 6, you can't really get 6, but sort of 4 and 5, you really want to start thinking of ITU. Not necessarily, but sometimes if their confusion certainly isn't going away with fluid and antibiotics, it's a pretty bad sign. This is our third, also just with the pneumonia, just give them a little bit of oxygen if they need it, but nasal cannula is often enough just to keep them going. One of the things that really helps is paracetamol. And if you're finding oral paracetamol isn't working, the same dose of 1,000 milligrams IV works wonders. It brings the temperature down and it also stops that pain. And if a person's not in so much pain, they tend to take deeper breaths, which helps. They also tend to be able to cough up a little bit more. And so that kind of gets rid of the infected sputum. And they're more amenable to things like chest physio, which loosens secretions and really does help. So yeah, let's just take a look at the third question. Chest pain worse on inspiration, it's pleuritic. When you examine him, there's chest expansion. His 100/66, heart rate is 93, dynamically unstable. And it shows a protein concentration of 38 grams per liter. Essentially, that means the fluid is an exudate, and the only cause of exudate that was here was arthritis. You can then class them as transudates or exudates. The short version is a transudate. Our person had an exudate. A transudate is essentially to either increase venous pressure, such as cardiac failure, overload, or constrictive pericarditis, or low protein syndrome, malabsorption, or hypothyroid, which is essentially where you get a ovarian tumor, ascites. You drain that pleural effusion. It just keeps coming back, but you get ovarian tumor is instantly resolved. An exudate, on the other hand, is cause of leaking pleural cavities from infection or inflammation, and also malignancy. When you've got a pleural effusion, you are generally quite short of breath and you have pleuritic chest pain. Essentially, where the fluid builds up, it puts a lot of pressure on the pleura of the lung. And that, when you breathe in, the pleura of the lung kind of gets sucked in and it kind of hits your pain receptors and also makes you catch your breath. So people often don't take such a deep breath in. So they tend to hyperventilate as well as being just short of breath because of the effusion. On examining the chest, you have decreased expansion, it's dull to percuss, and it's specifically stony dull. You get decreased breath sounds on that side, and your chest x-ray shows a pleural effusion, which is essentially a white blob of fluid, often with a meniscal line, which shows that it's fluid rather than infection. An infectional consolidation can often just look quite random, like a bit of someone's spray painted it, whereas with a pleural effusion, it's a lot whiter. Essentially, to manage it, you treat the underlying cause. So if it is something like Meigs syndrome, you get rid of that tumor. If it's something like heart failure, you manage the heart failure, you offload them, give them diuretics, etc. And also you can drain the pleural effusion. The way to check it is your bubbles should, so when you put the drain in, there's a little bit of water in the drain pot already, and it should start bubbling as soon as you put the drain in. People get quite instant relief, and it's also quite satisfying because they end up just sitting around. You're not really doing anything else for them except having this drain in, but just it bubbling quite often, people think helps. It does help to move around a little bit with a drain in, but not too much. A couple of months ago, I was on call, and we had a young guy who's about 29, I think. He had a chest drain in, and he was trying to move around loads in the room just to try and get the drain working and moving. He essentially moved a little bit too much, and the drain came out, but stayed in him, but it slipped out of where it was meant to be. And it was like that for a couple of hours, and all the while it was still draining. He didn't have pleural effusion, he had a pneumothorax. But essentially, he suddenly started feeling quite tight and uncomfortable, and bless him, he'd ended up with surgical emphysema. So just be careful when you're putting drains in, just make sure they are quite secure. Encourage a person to move around, but if they are going to move, just make sure they're holding onto their pot when they're swinging, because otherwise drains can get pulled over a little bit. So yeah, next question. Cool. So most of you want to go for a CTPA. A few people who start with a chest X-ray, and others with a VQ scan. Okay. Essentially, you've got someone again with pleuritic chest pain. Doesn't go anywhere else. She's got diabetes. She's got CKD stage 3 and hypertension. She recently broke her leg, so hasn't been able to walk as much as usual. Presumably it's in a cast, and she's a little bit immobile. She's got a raised heart rate. Her blood pressure, which she's usually hypertensive, is low. She's not febrile, and her SATs are reduced, and we've got no history of lung problems that would suggest that's her baseline. So essentially what you're thinking of are things that, and obviously it's a respiratory, so lung pathologies that can be caused by a little bit of immobilization in the leg affecting the lungs. So perhaps you're thinking of, she's got a DVT and it's now gone into a PE. And so you need to image that. Usually you'd go for a CTPA, but this lady's got chronic kidney disease and it's quite severe. It's stage 3. By stage 4, you're thinking about end stage, you're thinking about dialyzing. So the reason you don't want to do a CTPA in someone with stage 3 CKD is you don't want to give them the contrast that you need to. So you do a VQ scan, which is essentially ventilation versus perfusion. You inhale a radioisotope and you image that as it goes through your airway. Okay, so we are talking about PEs, so pulmonary embolisms. Essentially, it's when a clot gets lodged somewhere in the pulmonary circulation. Often, they start off as DVTs, so a thrombus in the deep vein, usually the saphenous vein of your calf, that has broken off, travels through the right side of the heart because that's where your venous return hits, and it gets lodged anywhere in the pulmonary circulation. Often it gets lodged to the right side, so it increases right-sided pressure, so you get a little bit of axis deviation on your ECG, but not always. It can also be caused by septic emboli, so people with endocarditis, little bits of those. You get little collections of your bugs, and they break off in the heart and they travel through the left side of your heart often even, and go all the way around, but and that kind of gives you a more systemic endocarditic picture. but sometimes they can just go straight into the right side and just get stuck. Right ventricular thrombi following an MI. So with MIs, you get loads of complications that can happen later on. And one of them is you can get a right ventricular thrombus, which isn't very common, but can be quite dangerous. But PEs aren't necessarily blood clots. They can also be fat clots, pockets of air, amniotic fluid, neoplastic cells, and parasites as well. They're a lot more common in pregnant people, and that's because pregnant women are more prone to clotting. They're in a pro-embolic state. If you've had previous PEs or DVTs, or you've got a family history of them. Malignancy is a big risk factor. Immobility, which is what Our Lady had. If you're taking the combined contraceptive pill or hormone replacement therapy, the progesterone pill isn't such a risk factor. If you've had recent surgery, not only because of the immobilization often follows, but also the trauma caused within that surgery. And if you've got any type of thrombophilia condition, so antiphospholipid syndrome, etc. Often people with antiphospholipid are on lifelong anticoagulation. Sometimes this isn't initiated until they start having recurrent clots and things like that. But sometimes, and it's often done based on a history of what they've been through, but also any family history they may have. And they may just be started on anticoagulation. A lot of people are still just on warfarin rather than one of the DOACs, which means they need their INR checking, which isn't ideal, but sometimes that is just the safest way. It's a lot easier to look at the INR and maintain anticoagulation with that rather than using a DOAC, which you don't necessarily, it's a lot more complicated rather to work out if you're anticoagulating someone well enough, or indeed if you're over anticoagulating them. Anyway, with PE, you are short of breath, you can't get enough oxygen in your lungs, and it's really uncomfortable. You've got chest pain, you're often tachycardic, and your O2 sats can be drastically reduced. I always thought that PEs were fairly rare. That I promise you they're not. And sometimes people can be really unwell with them. You image them, you start busting that clock. So you give them, for example, if they're in hospital, you go with an oxyparin treatment dose, and they get better quite quickly. Then obviously you need a bit of a prolonged course of anticoagulation. To investigate, you do blood tests. So you'll often have a raised D dimer. Sometimes you can have a raised CRP, but you won't have raised white cells. It's not an infective process. But your D dimer is in your blue bottle. By raised, anything over 500 is not great. If it's over 1,000, think DVTs, PEs, but you can get it over sort of 2,000-3,000 even. You go into type 1 respiratory failure. So if you do an arterial stab on something, you do an ABG, they'll have low oxygen, but you know that from their oxygen sats. They won't be retaining CO2. They'll be tachycardic. Ideally, you'd want a CTPA, which is a CT of the pulmonary arteries. If you can't do that, go for a VQ scan. The benefits and risks of them in pregnant people can be argued, but essentially in young people, in pregnant people, or in people who can't have contrast, go for a VQ scan without question. And yeah, you manage them, like I said, with anticoagulation. If someone has recurrent PEs, you can put in a filter into the vena cava it's in the inferior vena cava because that's where your problem is, rather than in the lower end. Yeah, the only problem is sometimes if someone's in a very coagulable state, so if they've got incurable malignancy and you put a filter in, sometimes that filter will get a thrombus around it. So then you're dealing with them often getting Ps, because that's unfortunate, but it happens with their malignancy. Then you've also got a little bit of an increased risk because you've now got an IVC filter, which also has a thrombus around it, which can break off and get lodged into your circulation. And so you have to really anticoagulate these people. Sometimes you just remove the IVC filter, but that's not always possible and it's not always in the patient's best interest. Okay, next question. I'm actually going to close this and just go back a little. Sorry, just talking about what you see with these people. Their O2 sats, they're reduced and they don't necessarily come up when you put them on oxygen. And that's essentially if they can't, like they sometimes just can't get enough oxygen in. So you can put them on 15 meters and it still doesn't go away. Yes, obviously panic about it, but then just get your bloods rushed through, get your ECGs done as well. With Ps, you can often get ECG changes as well. They're not as common as one would hope, but they do occur. And so always do an ECG on these people as well. Don't worry so much about anticoagulating. Even if they've got low platelets, that's okay. Their low platelets are probably more chronic, that you might have to choose a different drug. Often in hospital, they'll start on Clexane or enoxaparin, or indeed doldaparin. But to go home, sometimes that continues and you inject yourself with inox for 3 months, for example. But also you can go on to a DOAC, so edoxaban or apixaban or something, which for some people is a little bit easier. Generally, that's not done for the first presentation of PE, but if this person starts getting recurrent PEs, certainly if you're thinking about longer term anticoagulation, I'd go with the DOAC. Anyway. So you've got sudden onset, pleuritic chest pain in a young, thin gentleman. When you percuss, it's not just resonant, but it's hyperresonant. He's hemodynamically not stable. He's got a lowish blood pressure, but his heart rate's quite high. He's quite tachycardic. And his rest rate's 28, which is pretty high. He's afebrile, and on his chest x-ray, on the right, you've got quite normal lung, but on the left, it's a lot blacker than you'd expect, so that you can't see lung markings, etc. But if you take a look at his trachea, it's deviated, and it's deviated towards the right, which means something is either pulling it towards the right or pushing it away from the left. In this instance, it's being pushed away from the left to the right because of a buildup of air in the space where the left lung should be. But the left lung has actually collapsed. And if you take a look here, you can actually see where that lung is. And all of this, that it's not lung, it's just air. So this person has a pneumothorax and they've got a tension pneumothorax, which is why it's pushing the trachea over into the right. You deal with this with decompression in the second intercostal space, midclavicular line. So pneumothorax. It's the presence of air in the space between the lung and the chest wall. It causes the lung to collapse, and then that space fills up with a little bit of air. It's often spontaneous, so that's not uncommon in young, tall males. but you're often at higher risk if you've got asthma or COPD, if you've got TB, malignancy, cystic fibrosis, connective tissue disorders such as Marfan's, which you can think of in sort of young, tall males. Following trauma, often if people have been stabbed, you get really bad pneumothoraces, and sometimes it could be iatrogenic. So it could have been us in hospitals, and we accidentally give someone a pneumothorax. For example, when we're putting in a chest drain to drain a pleural effusion, you can cause a pneumothorax. And then you've got two problems to deal with, which obviously your patients write you brilliant thank you letters for. Anyway, you get asymmetric chest expansion because one side won't be filling up, the lung won't be filling up with air. It's the space that's filling up with air, so it's not expanding. It's hyperresonant percuss. You don't hear breath sounds on that side because the person isn't breathing from the affected side. You can see it quite clearly on a chest x-ray. With a simple pneumothorax, you can conservatively manage it. It often goes away itself. Make sure you give these people adequate pain relief. Sometimes you need a little bit of oxygen until it's decompressed a little. And then they tend to go home with follow-up x-rays in about a week to see if it's fully resolved or if it's going in the right direction. A tension pneumothorax is essentially, as we said, a pneumothorax, but then the air is drawn into the pleural space during inspiration, but it has nowhere to go, and so it builds up in that pleural space. Essentially, this causes the mediastinum to be pushed over into the other side, so the contralateral hemithorax. This causes vessel compression, Essentially, that leads to cardiorespiratory arrest unless you deal with it. So if you've got a pneumothorax, you should be able to tell by percussion that this is a pneumothorax, and also feeling the trachea, it'll be deviated. Don't wait until you get a chest x-ray to confirm. Just go straight for needle decompression. The most traditional route is to go into the second intercostal space, mid-clavicular line. Some people will go into the fifth intercostal space, mid-axillary line, but you need a different needle, and that's sort of new evidence coming up. But the best place, second intercostal, mid-clavicular line, get a hissing sound as the air is escaping through your needle. It gives the person quite instant relief. Then you can give them a chest x-ray, confirm that they've got a pneumothorax. They're now no longer in tension, hopefully, because you've decompressed them. And then you can pop a chest drain in. If you've had someone go into tension with their pneumothorax, don't go for just conservative management. Always put a chest drain in, because it's got to the really bad stage. You don't want to risk it getting any worse. You just want to deal with it completely. And you've also been quite invasive by shoving a needle into their second intercostal anyway, so. Okay, I was going to do a little bit of a talk on COVID just because it's quite topical at the moment. But before I do, if anyone has any questions that they want to ask, I think that the chat is open and you're very welcome to ask them on that. And again, sorry as well, if you've got any questions that you want to ask about COVID itself, just let us know. Okay. So if anyone does have any questions that come up, fire away. I don't have anything other than this slide for COVID, but essentially, we all know what causes the infection. It's a virus. It's a SARS virus, and it's not something we have a full-on cure for at the moment. A lot of people will have it and not get symptoms, whereas other people can get quite bad symptoms. And as I'm sure everyone's aware, you're at higher risk of getting worse symptoms if you've got an underlying health condition, you're immunocompromised, or you're a little bit older. Essentially, if you're looking at imaging of COVID, your chest x-rays have what's called bat wing shadowing. So with the lateral sides of the radiograph, you'll have almost a consolidative picture that spreads out from the middle. I think it looks more like a butterfly, but apparently it looks like a bat wing. So there you go. A lot of people get CT scans. A lot of them are CTPAs, because with COVID, you're more likely to get a PE, but also it raises your D-dimer itself, and D-dimers are often done in ED. And then if it's raised, you have to do something about them. Though now hospital policies are coming up saying, actually, you don't have to just scan everyone who's got a raised D-dimer. If you can account for it because of COVID infection or whatever, that's fine. But what you get is you get what's called ground glass noduling. So it looks like someone stepped on a little bit of windscreen and then ground it with their foot and just shove that everywhere in the lung. It's a fibrotic picture, essentially. And it's because of that people often find it a little more difficult to breathe for a little while afterwards. You may have heard of people using dexamethasone or remdesivir for people with COVID. Essentially, if someone has an oxygen requirement, they're often, if they're in hospital, well, if they've got an oxygen requirement, they are in hospital. But they're often put on something called remdesivir, which is given IV, but it should be stopped. It's every 24 hours you get it. You start off with 200 mg and then it drops down to 100. But you want to stop it as soon as that person doesn't have an oxygen requirement. The dexamethasone, you put them on 6 milligrams and you continue it for a 10-day course. That's not to say everyone who has COVID should be given Dex. They probably shouldn't. You have to be quite careful with things like blood sugar control and stuff like that. And obviously it is a steroid, so it's not ideal. If you don't need it, don't have it. But if you start the course, you should finish it. We're not 100% sure why it's working, but it's similar to an asthma. You want those airways opened. It essentially opens the airways. COVID is affecting patients in ways that are changing quite a lot. And that's because we're now seeing different people getting COVID. So at first we were seeing the more immunocompromised or the elderly, or people with possible vitamin D deficiencies, which is where the BAME people were more likely to get COVID. But actually now we're even seeing younger people, Caucasian, not immunocompromised, perhaps those that have been socializing a little more. And it does different things to them. But essentially one of the things that it's really been doing is making people feel really shit and really isolated. And there's two reasons for that. Obviously, we're currently meant to be in a lockdown, so that's probably not helping. But also you have to isolate yourself and people stay away from you for 14 days minimum. And people can get quite judgmental about, oh dear, you got COVID, so you're obviously not following the rules. That may or may not be the case. But also it can make you feel so unwell that your body's just really tired. And if you're tired as it is, you often feel a little lower in mood. But if on top of that you shove in a pretty awful infective process that not a lot of people know about, and you're quite scared, which a lot of people who are getting COVID infections are, especially if you're in hospital, then that can reduce your mood as well. But it also, if it's something that obviously everyone talks about, the impact of COVID on the lungs and things like that, and that's absolutely true. It does have longer lasting impact on lungs, but it can also affect other organs. So increasingly, we are noticing people having mild kidney injuries with COVID, but that doesn't always go away, or it takes a little while to go away. So it can impact on your kidneys. We've spoken about your mental health. It can also give you a bit of an upset stomach. And then if you've got an infection, and as in a bacterial infection and COVID, and you're on antibiotics, your gut's not going to thank you. But there's also something called post-COVID syndrome. Essentially, this was first thought about because people were exhausted and just fatigued for, even a couple of months after getting COVID. But you get something like brain fog. So, for example, there was a gentleman who would play the piano twice a day. It was his morning routine where he'd have his morning coffee and play the piano, and he'd go to work and come home and play the piano to wind down. During COVID, he just wasn't going to work, but he'd do his normal chores, and he'd be working from home, and in the evening play piano. He then got COVID. He didn't need to go into hospital for it, but he was exhausted. And then afterwards, so he hadn't played the piano for about 4 or 5 days, and he thought, okay, I want to start getting back into this before I forget what I'm doing or before I become de-skilled. He then started trying to play the piano, and actually found he wasn't able to quite so much. He said that he was losing concentration. He wasn't able to remember the notes, and he needed his sheet music in front of him, etc., etc. He set up something online just asking people about this, and a lot of people commented. This was taken quite seriously, and we've actually found that there's a little bit of a mind fog that goes on with COVID that can come up really quickly, but it can last ages. And by ages, there are people who don't get over it within sort of 4 or 5 months, and they've only had symptoms that they would otherwise have attributed to COVID for about 3 or 4 days. So I think that's one of the things that we're going to find a lot more with time coming up is actually our post-COVID patients, as well as those who at the moment have COVID and will get it over the next couple of months. I think increasingly, and I can imagine the sorts of patients you'll see in hospital as well, will be those with post-COVID syndromes. And if you're in GPs, I think they'll be coming up a fair amount more as well.